Yes. Okay, great then. Okay, so lovely to meet all of you, by the way. I know often you guys do case presentations. I'm going to go a little bit more into some of the background with this type of treatment. I think that's perhaps more helpful because it will naturally lend itself to what types of patients this would be ideal for, although I'll touch upon that during the talk too. I was told I'm limited to 25 minutes, so I'll do my best to get through. But I'm going to talk about cervical sympathetic blockade, specifically for post-traumatic stress and anxiety disorders. And disclosures, I don't have any. I am the physician owner and medical director at my center where we do these interventions as well as some other treatments for mental health and trauma, but I don't have any industry sponsorships. As I mentioned, my background's in PM&R and interventional pain management. When I moved to Ohio about 15 years ago, I did a lot of addiction treatment, primarily opioid addiction treatment, medication-assisted treatment, and chronic pain management. But about 5 years ago or so, began to recognize some of the frustrations, honestly, with a lot of remission and relapse, a lot of uncontrolled symptoms, and a lot of symptom-based care that wasn't productive. And so when I learned about some of these other treatments, we had started utilizing these treatments in my former practice. We saw success. I connected with some folks around the country that were doing this. And in 2024, set up my center, Reset Medical and Wellness in Strongsville, where we do these treatments to really facilitate root cause management of trauma. Obviously, in addiction treatment, which I know many of you are in addiction treatment, and of course in the chronic pain world too. Many of these patients are struggling with trauma as the cause of a lot of their current issues. So it kind of made sense to me. And we wanted to do that in a setting that was trauma informed and welcoming and a little bit different than your typical medical center. So if you've ever felt constantly on edge, like your body won't relax even when your mind wants to, you're not alone. That's what I tell my patients. Obviously, as all of you likely know, currently there is an epidemic of um, trauma, anxiety, depression, deteriorating mental health. 20% of the country suffers with anxiety or depression primarily, but some type of mental illness. 12 million have PTSD, and that increases the suicide risk by fourfold. Probably an underrepresented number, honestly. I treat about half of my patient population is veterans and first responders, so I have a particular interest in their mental health, and sadly, their numbers are much worse. A third of individuals who've been in the military develop post-traumatic stress. They have a significantly higher suicide risk, and about one veteran is lost to suicide every 80 minutes or so. The unfortunate part about these statistics is that more than half of those individuals have not had recent VA contact with a mental health provider. And it's not always because they haven't had contact. Sometimes, again, they've given up on that contact, right? They've become exhausted because despite best efforts, they didn't see progress quickly enough. And and that's where we're trying to intervene earlier, particularly in those treatment-resistant cases, where we can really make an impact so that they can start to see that progress. And that's what sympathetic blockade is really all about. And the other thing that I think is important when we're talking to any individual, but particularly we see this importance in those struggling with trauma and first responders and veterans that are reluctant to accept that diagnosis. when we talk about this as an injury, which it really is a physiologic change, it reduces some of that stigma. It allows people to feel that treatment is more practical. And I'm going to talk today a little bit about some of the neurobiology, a little bit about what that injury actually looks like and how, talking about it like that to our patients can really create a lot of hope for recovery because just like any other injury, it's something that we can heal from. And so when we talk about that injury, it goes back to understanding a little bit about our nervous system and how trauma affects us. So in general, human bodies are very good at acclimating to their environment. Whatever that environment is, it's happening all the time, and it's happening right now to every single one of you. Your nervous system is sensing the temperature of the room, sounds around you, smells, sights, etc., and assessing constantly if there's threat. And if there is a change in temperature, a change in altitude, your body makes those adjustments. The problem is when you're exposed to chaos, intense situations, chronic stressors, traumatizing situations, um, for long enough, or in severe enough cases, those situations start to cause acclimation of your nervous system. Your nervous system starts to condition itself. So the default response becomes our fight or flight state. And what this unfortunately leads to is physiologic changes within the brain where it's changing metabolic activity in areas that are sensing threat and increasing sympathetic nerve signaling. So it becomes this feedback loop, and I'll talk more about that. But the real challenge is that even when the patient is removed from those stressful situations, right, that doesn't change the physiology. It's not a state of mind, right? It is a injury that has occurred that regardless of where they go after, their body is unable to feel or sense safety because everything is threat. And that's where the real problem is. And that's where the challenge in treatment is. And when we look at these images, now we have SPECT scans. This is a functional MRI scan. We can actually see this increase in activity. This is one of the earlier scans. They were looking at glutamate activity particularly, but the punchline here is both patients at rest. You can see there with the reds, the yellows, that's increased activity in the patient with post-traumatic stress, even at rest, whereas that activity is lessened. And we've looked more into this, and that's what I'm going to talk about in the next several slides. Um, Specifically, what individuals have looked at is areas within the limbic system that are particularly affected. Within the amygdala, that's our threat detection center, um, we see increased activation, so increased metabolic activity. And that includes other areas within the limbic system, including our hypothalamus, our insula, our hippocampus as well. All those areas are affected, but the amygdala particularly we see this increased activation. So this increased threat sensitivity. And then what happens is typically we talk about top-down emotional regulation, where you're able to sense where what your environment is and cognitively deduce that you're safe and allow yourself to get to a more calm state. Um, but the problem is in these patients, what we actually see is the prefrontal cortex, which controls that top-down emotional regulation, has reduced activity. So that adds to the problem. Then further complicating the problem, what we see in the hippocampus is that the volume of the hippocampus in patients with trauma is actually smaller. So our hippocampus is our memory formation center. And it's particularly critical when it comes to trauma in a process called fear extinction. And if you're not familiar with that, that's the idea that when you have a trigger or something that affects you, that contributes to threat or fear, you can expose yourself gradually to those threats, reinforcing safety, remembering and reprocessing those fears in a more healthy way, right? It is the basis for a number of different therapies, from obviously exposure therapy, exposure response prevention, even when you talk about cognitive behavioral therapy, certainly EMDR. Those are times where, in order for those things to be effective, you have to reprocess those memories in a more healthy way, in a more functional way. And when your hippocampus is impaired, that's a problem. What we don't know, the obvious next question is, well, if is that a result of trauma, or is that something that predisposes someone to trauma, a smaller hippocampus? We don't know the answer to that, but regardless, that is part of it. And the other thing, oops, sorry. The other thing that is important to note is it's really not one center that's problematic. It's really a dysfunction of this network. And when these issues arise, it's we see this expanse of changes. It's not a change in one specific area, and it's really a network dysregulation. And of course, what this creates then is this imbalance between a hyperactivation of a warning system and a suppression of your safety system, which is the actual injury in trauma. The brain essentially becomes wired to this high alert threat mode. When that happens, when this becomes the default, all sorts of symptoms, as many of you are well aware, then result. So sometimes it's anxiety and panic attacks and physical symptoms of anxiety, like GI issues and tension and headaches. Sometimes it's a freeze, it's a shutdown, it's depression, it's chronic fatigue. Sometimes it's fawning. That's actually probably one of the most common things that I think we see. I certainly see a lot of this people pleasing, maternal instincts, helping everyone else, but not looking inward. And of course, when these go on for too long, just complete emotional shutdown is often the case. So, other than traditional treatments, what can we do to intervene earlier? And that's where sympathetic blockade comes in. The stellate ganglion is a collection of nerves in our neck. It is part of a larger system, the sympathetic system, which is one half of our autonomic nervous system. Sympathetic system controls our fight or flight response. The parasympathetic controls our rest and recover response. And the stellate ganglion is particularly important because it is a central hub for the signaling from our brain, from our limbic system, to the majority of our important control systems in our body, from our cardiovascular system to our adrenaline release, adrenal glands. And this has a direct impact then on how this system is functioning when it's dysfunctional. And what we see is this constant feedback loop. So there's an event that creates this exaggerated stress response, this increased threat warning system on alert, activates a signal to the stellate ganglion, which then sends that signal to the body to do all the things, increase blood flow to the extremities and increase cardiovascular output and reduce blood flow to the gut, increase adrenaline, cortisol, all the things. But then importantly, that actually sends a signal back through that same sympathetic chain back to the brain to reinforce this, to make it happen faster the next time. And that's when this cycle continues for so long, what is very difficult to break. And that's where sympathetic blockade can be helpful. What we do is we place a anesthetic. We typically use ropivacaine, but other anesthetics can be used along that chain of nerves in the neck, interrupting that signal, interrupting that feedback loop, pausing it essentially. And by pausing it, what it allows that system to do is start to recalibrate. That's, what I tell my patients. What's actually occurring anatomically is it's reducing norepinephrine. in the brain, and it's lowering that metabolic activity in the limbic system. It's also reducing excessive nerve growth. It reduces nerve growth factor and brain-derived BDNF in a process called adaptive neuroplasticity. But the idea is it's sort of pruning those excessive branches that the sympathetic system has connected to our threat response system. Because that's when that's very sensitive and that signal is being sent constantly, interruption of that signal reverses those processes very quickly. And by the way, we call this, I didn't mention this yet, we call this neurosympathetic reset. That's where that acronym NSR that you see at the top there is. This procedure goes by a few different names. So sympathetic blockade or cervical sympathetic blockade is the medical term. You might hear stellate ganglion block. Um, NSR is really just a take on that. But we do a different approach to this by blocking a couple areas along that cervical sympathetic chain. And studies have shown that that is more effective by having a more complete block of that nervous system, essentially ensuring that that system is completely shut down, a more effective regional block. And so we block at C4 and at C6. So it's a stellate ganglion block plus, if you will. Um, and we do both sides. And that's also important. That's been shown in literature to be significantly more effective than a single side. And the interesting thing is that this isn't new. This is a block that has been used historically in medicine for 100 years to manage pain. It came about after World War I when they were having military that were shot in the upper extremities have these consistent nerve pain. Essentially, this nerve pain created a threat response that alerted the sympathetic system to react. And then that extremity has this increased sympathetic output, and it causes a condition called complex regional pain syndrome. And it's a very unique and somewhat rare condition, but in the pain management world, we see it all the time. And it was something that we would regularly use a sympathetic block to manage. It was really only in the early 2000s when they started to realize that, well, what if we block the sympathetic system for these other conditions that are also having autonomic dysfunction, that are having excessive sympathetic output? And of course, lo and behold, it was helpful for many of these conditions. Um, and it was kind of, to some degree, found almost accidentally because they were doing this block for vets that had lost their limbs and had phantom limb pain and regional pain syndrome. And they were reporting that their trauma symptoms, their nightmares, and their hypervigilance was improving with these blocks intended for pain. And now what we know is that patients with particularly treatment-resistant post-traumatic stress and anxiety disorders have significant benefit, and upwards of 70 to 80% in the literature, which I'm about to go through in a minute, have shown clinically meaningful benefit and lasting benefit after this treatment. But other symptoms, like menopause symptoms, which are sympathetically mediated, long COVID, which is a chronic inflammatory condition that's often mediated by the sympathetic system, as well as some other conditions that are particularly keen interest to me, have shown benefit. Of course, I can't get into all these today, but it is interesting. The actual block is very simple. It's, if any of you are familiar with regional anesthesia, it's very similar to that. It's a similar approach using ultrasound. The block itself only takes a few minutes, is usually done with local anesthetic or very minimal IV sedation. And there are some temporary effects we expect. There's a Horner syndrome, which is a droopy eyelid, warmth in the face, and congestion, constricted pupil. These things we like to see. They wear off very quickly, and patients start to notice the improvement, which is what's so nice about this treatment, within days, and sometimes even quicker, sometimes within hours or minutes, sometimes even while they're still on the table with the needle barely removed from their neck, and patients have a release of emotions that has just been blocked because this trauma response has been so ingrained in their physiology. And we follow these patients. I follow them from an objective standpoint for my research out 2 years. We follow up subjectively through 6 months. Um, the idea here, though, again, and I want to really emphasize this is not intended to be a standalone treatment. This isn't like, A or B. This is something that can create a buffer, right? It allows patients' stress response to react in a more healthy way to their triggers so they can integrate treatments more effectively. And that's also what the literature has shown. And I'll point that out in a minute. But that's really what's critical, right? It's this catalyst for deeper healing. It's this ability to then integrate those traditional treatments more effectively that really makes this a game changer for a lot of individuals. And so looking at the literature briefly, and I have all these references and they're on my slides. So if anyone wants to look at them, they're welcome to. And I'm happy to talk about the science. I love that. But this was, so like I said, a lot of the earlier studies were from the early 2000s. And it was in the 2010s that really some of the bigger studies started to come out. So it is, in terms of medicine, a relatively new treatment. And this was a study done by my colleague Sean Mulvaney over on the East Coast, and he showed that in a retrospective analysis of 166 patients, that about 70% of them were having a 10-point or more reduction in their PCL5 scores. The average improvement was 22 points, which is reflected also in my data and anecdotally what we're seeing as well. Pretty significant portion of patients that respond to this. Now, this was specifically in military, and most, to be frank, most of the studies to date have been done on military because it's frankly widely accepted and more well known in that community. But we're trying to kind of bring this more to the civilian community as well. There was a RCT published in JAMA in 2020. That was a nice study that compared SGB to a sham injection, and it had clinically significant improvement, about twice the improvement in a clinically administered post-traumatic stress scale, CAPS 5. That might be wrong, but I think it was the CAPS scale, as compared to a sham injection. And it was the first RCT. There's a couple other large RCTs that are multi-center going on currently. We're looking forward to the publications, hopefully by the end of this year or next. A lot of people ask, of course, how long does this last? That's probably the most common question I get. And the idea here is that, again, because it's a catalyst for this change, as opposed to how we use it in the pain world, where it does have to be kind of repeated periodically. This is something where patients are maintaining that benefit for quite a duration. We're seeing months to years. This study was just done recently, came out, I think, last year, and showed that patients are not only having a significant drop in their PCL5s, but it's happening within a week. So the first time point here is 1 week out. And that benefit is being sustained out 6 months. Some of the longer studies, including mine, we're looking out beyond that. But anecdotally, what we're seeing is these patients are maintaining that benefit in a good portion. To be frank, not all patients respond, obviously, and the ones that do respond, a portion need this repeated. We see about maybe 20%, maybe up to a third of patients need this repeated. But that's most common in folks that either don't have the support that they need or are put in situations where they're re-traumatized. That might be active military that are going back on deployment. That might be first responders that are going back in the field. That does have the potential to reactivate this nervous system effect. Um, and this was my colleague Craig Bryan down at OSU, and he showed that just what I was mentioning earlier, that when combined with cognitive processing therapy, one of the classic treatments for post-traumatic stress, um, it really enhances the benefit. But not only that, this was an interesting study where they took the two cohorts, treated one with SGB, one with cognitive processing therapy. Both, of course, improved overall. But what was interesting is those that didn't improve with cognitive processing therapy or had limited improvement, they then did a crossover, took those patients at a point down the road and treated them with SGB and saw that they actually then had improvement. And so SGB, obviously before cognitive processing therapy is great, but even especially perhaps in those patients that are resistant to treatment, that's where we're really seeing a breakthrough. And that's where I think that this can be particularly important, again, in patients that aren't progressing, right? I mean, I would love it if every patient could do, a few months of therapy and take some Celexa and they're great. But the reality is that's not the case always. And so utilizing treatments like this in those treatment resistant cases is what's important. And then this is my study, and we're looking at the long-term effectiveness of this treatment, both for post-traumatic stress and moral injury in special operators, Navy SEALs, Green Berets. And we're looking at out 9 months. Again, we just want to see how far this can go and compare how patients do as they integrate those different treatments on their own. Common question, again, because in medical terms, this is a relatively newer treatment in the last 20 years. It's not yet covered by insurance. We're hopeful that that will change. Um, there are a few VAs that their TRICARE will cover this, but it's not particularly common. So unfortunately, at this stage, it's not. We try to make it affordable, and we work with a lot of nonprofits that actually provide grants for certain individuals, those in financial need, those that have special circumstances, for vets and first responders. And so in 2026, this year, we've provided over 100 grants for patients, meaning 100 patients had this treatment at zero cost to them, because we were able to work with these nonprofits that we've partnered with, which is great. Um, and I think that was pretty close to 25 minutes-ish. So hang on, I'm gonna unshare my screen. And if there's questions, I'm happy to take them.